Welcome to our Mary Greeley Primetime Alive program, What Goes Wrong with the Urinary Tract. I'm Vicki Newell. I manage the Primetime Alive program here. As a reminder, if you would like more information about Primetime Alive, to join or sign up for a program, you can visit us at mgmc.org/PTA. Our presenter today is Dr. Charles Paul. Dr. Paul received his Bachelor of Science from Iowa State University, his Master of Business Administration, his Doctor of Medicine, and completed a urology residency from the University of Iowa. Dr. Paul joined McFarland Clinic in September of 2023. Please welcome Dr. Paul.
Well, good afternoon, everyone. Thanks for being here. Appreciate everyone taking the time out of your day to talk about the urinary tract, which may or may not be what everyone likes to spend their Thursday afternoons talking about. It's usually what I do, at least. So I wanted to focus on a couple, common things that can affect individuals, really of all ages, but especially as time goes on, things that can go awry with the urinary tract. And so no industry disclosures from my perspective. But first, a little bit about me. Just heard kind of my educational background, but the Iowa map pretty much says it all. So I've been a lifelong Iowan. I grew up in the Quad Cities in LeClaire, Iowa, a little town just upriver from Bettendorf and Davenport. I went to Pleasant Valley High School, which is in the town of Bettendorf, but came here to Ames for undergrad, went to Iowa State. I actually had a double major in kinesiology, so sort of human physiology and exercise science, and then I also had a double major in finance. I ran on the cross country and track teams here, so that also was a big part of my college experience, and also a little bit explains the odd combination of majors because I had gotten through the kinesiology major and I wanted to run a fifth year in college, and so I had to fill it with something else. But I'm really glad I did because the finance education has been very helpful. So from here, I made the difficult move east to Iowa City. I'm still a pretty big Cyclone fan, so a decade in Iowa City was great, but very different than here. So I received my medical degree from the University of Iowa, and then I stayed on for my urology residency at the University of Iowa Hospitals and Clinics. We actually had a built-in non-clinical year as part of our residency training that you could either use for research or a master's degree, and so I used it to get a master's in business administration. So another really nice life experience that I enjoyed doing for that year, and then was very happy to return back to Ames just this past summer. And so I finished my urology training back at the end of June of last year, and then it's been a lot of fun moving back to Ames as an adult, very different than being here as a college student, but a lot of fun. Moved back with my two girls in my life. So I've got my wife, Carly, and my little 2-year-old Peggy. Sign of a successful 2-year-old is the bilateral Band-Aids on both knees. That was when it was a little warmer a couple weeks ago, and we were down in Kansas City for the Big 12 tournament. So they're both great, and Peggy's definitely a lot of fun. So what in the world does a urologist do? Some of you may have been to a urologist before. Some of you may have never heard of it before. I probably had no idea what a urologist was before I went to medical school, and probably even a year or two into medical school. But, in short, we treat problems of the urinary tract. And so that can include anything the urine touches. That's the kidneys, the ureter tubes that drain them, the bladder, the prostate for men, the urethra, and anything that can go awry in one way or another with those things. We also deal with problems of male reproductive health. We treat both male and female patients. I think that can be sometimes a misconception of, certainly we see a majority male patients if you break us down, but we see a lot of women as well. And we do both medical and surgical treatments. And so we're definitely dealing with a lot of things in clinic that are focused on, medical management, observation, medications. But we do a lot in the operating room and procedures in clinic as well, too. So really a broad specialty as far as things that we take care of and things that we see in clinic on a daily basis. What does go wrong with the urinary tract? So we're going to talk about a couple sort of categories of things today. I'll break it down into things that are going to make your life shorter, which is primarily cancers of the urinary tract. Today I'll focus on the most common ones that we see. Of course, anywhere in the body, cancer can develop, but today I'll focus on the kidney, the bladder, and the prostate for men. And then there's things that are maybe not going to make your life shorter, but they're definitely going to make your life worse as far as quality of life goes. And that is kidney stones, enlarged prostate, of course, also for men, urinary incontinence for men or women, and recurrent urinary tract infections. And, of course, the caveat here is there's lots of overlap between these two categories. So certainly having a cancer diagnosis is also going to make your life, from a quality of life perspective, somewhat worse. And, vice versa. There's some, severe cases of kidney stones, infections, et cetera, that can also potentially have the capability of limiting or shortening life as well. So let's talk with a little bit overview about urology cancers. Here is from at least 2023 estimates, the most likely cancers that you can develop and the estimated deaths from various cancers. And so I'll highlight the ones that I deal with on a daily basis. You can see there definitely more male tilt than female, but we've got prostate leading the way as far as cancer diagnoses for men, but at least it's not the number one slot as far as prostate, as far as deaths from cancer. And so we're doing something at least there to help blunt that. We've got bladder, kidney cancer, also bladder down here for men. And, women far less represented in numbers. Some of that's just based on the more common female cancers, such as uterine and breast, being more common than kidney. Of course, women also do not have a prostate gland, so that takes that off the table. But doing well here with not represented on the cancer deaths for women whatsoever. Talking about prostate cancer, first here, it's of course, most common and second most common cause of death from cancer in men. Typically in this day and age, we catch it with a lab test called PSA, which stands for prostate-specific antigen. That's something that's usually a screening test. So it's something that is drawn by primary care doctors or providers, anywhere from age usually 50 to age 70 or so is kind of the prime time screening that I'll talk about. It's usually not something that comes on with symptoms. So I'll talk about enlarged prostate in a little bit, but usually prostate cancer and enlarged prostate are two separate processes that may or may not be happening simultaneously, but usually they are more separate. The U.S. Preventive Services Task Force has some recommendations for prostate cancer screening. They have a grade C recommendation. We don't need to get into the nuts and bolts of exactly what that means, but essentially they say it's a good idea after discussing with your doctor from age 55 to age 69. They have less of a recommendation of a grade D response or recommendation after age 70. The American Urologic Association and the Society of Urologic Oncologists, that's more of my tribe, say that anyone that is high risk for a prostate cancer, and I'll tell you what that is, should be offered screening a little bit earlier, age 45 to 50. And then pretty much that same time frame, age 50 to 69, people should be offered. Doesn't need to be yearly, but every 2 to 4 years. Those risks that put you at a greater likelihood of developing prostate cancer primarily is first degree relative. That's going to be your highest risk, especially if that relative has had cancer diagnosed before the age of 60. There's some folks that have known genetic mutations that can put them at a higher risk for prostate cancer. They can be at a higher risk, and African American men tend to be at a slightly higher risk for prostate cancer as well. The thing to know here about the screening purposes, well, why in the world do we cut it off at age 70? And the primary reason for that is that prostate cancer in general is a pretty slow moving entity. And so between, catching prostate cancer and treating it, after treatment, it usually takes about 10 years of life after that until you benefit from the survival. So if, in other words, it's probably not going to kill you in 10 years, so why worry about it, type of thing. Mostly because the treatments we do will have some sort of negative quality of life impact, and we certainly don't want to do those if we're not going to see a payoff down the line. Now, the thing I mentioned earlier is prostate enlargement and prostate cancer are different things. Yes, they can happen in the same prostate gland at the same time, but not the same thing that we're talking about. Ultimately, diagnosis of prostate cancer relies on a biopsy. So you have to get a piece of tissue, have the pathologist look at it under the microscope. There's all sorts of grading scales that they can look at for the aggressiveness of prostate cancer, how serious of a thing it is, and what type of treatment or observation it may require. In this day and age, oftentimes we start with an MRI of the prostate. That's been a pretty big sea change over the last 5-10 years, where MRI has gotten a lot better. Our radiologists have certainly got very good at identifying areas on MRI within the prostate gland that may be more suspicious for a prostate cancer. And then what this image shows here is we can actually use the MRI guidance to focus on specific areas within the prostate gland that might be harboring the cancer. So instead of taking a systematic or, quote, random biopsy sample, you can actually go after a specific lesion. So this demonstrates if this yellow area is the one region in the gland of prostate cancer, all of these little lines here are the standard biopsy needle placement that would have missed it. And so having that MRI sometimes allows us to diagnose prostate cancers we otherwise would have missed and helps improve our sensitivity and the yield from doing a biopsy. Now, lots of different ways of treating prostate cancer, a little bit beyond the scope of today, but in general, we either rely on observation, so not doing anything at all, just monitoring as time goes on. When we are treating prostate cancer, we usually rely on either surgery, that's usually to remove the prostate gland, radiation therapy to treat the prostate gland and kill the cancer within it, either hormone therapy or, in more rare occasions, chemotherapies, but oftentimes not needing to be utilized. Surgery usually in this day and age is done with the surgical robot. That's this contraption here. It looks kind of like a big tree trunk with a bunch of arms. But what that allows us to do is use a number of small incisions and get a great view down into the bottom of the pelvis where the prostate sits. Compared to open surgery, it's a less risk of blood loss and blood transfusion, and helps with some of the postoperative outcomes from surgery. You know, radiation treatment is kind of what this guy's dealing with here. If you get to come in for a series of treatments and lay on a table, and there isn't an actual beam that you see here, but get a series of treatments over weeks to up to a month, and certainly less invasive. And pros and cons to all these things, but really it's matching the right treatment with the treatment preferences of the individual patient. Moving on to bladder cancer, this is definitely one, as you saw earlier, it's more represented in men than in women. Risk for getting bladder cancer, far and away the number one risk is tobacco use, so smoking. So there are certainly some people that have not been smokers in their life, but the vast majority of the folks that we see did have some tobacco exposure at some point in their life. There are some sort of occupational exposures, some very specific factory work that can put you at risk for developing a bladder cancer, or certain chemotherapies or radiations that were done for other reasons within the body. And then, chronic inflammation or chronic infections within the bladder at times too. The primary symptom of bladder cancer is blood in the urine, and it's very specific that it's usually painless blood in the urine, not like you would have with a urinary tract infection or a kidney stone or something else, but blood that just kind of comes out of nowhere for no good reason is always something that we would like to know about and like to see people for. And so, like I said, painless, and in 35% it's usually gross hematuria, which means blood in the urine that you can see. And less number, it's microscopic. The diagnosis for bladder cancer relies on looking in the bladder, and so that's called a cystoscopy. That's a quick procedure that we usually do in the office. Doesn't sound the most exciting, I'm sure, but most folks tolerate it pretty well. We kind of numb up the urethra tube and slide a small scope in, and then visually we can look at the entire area within the bladder and see what's going on in there. Staging, sort of the degree of concern for the cancer, is completely based on the depth at which it grows into the wall of the bladder. So if you imagine the prostate or the bladder cancer like a tree, I care a lot more about the roots of the tree than what you can see or the trunk growing above ground. And so here you can see this is your bladder. The bladder has a number of different layers through the wall here, and what layer the tumor has grown into helps dictate the type of treatment that we do for it. Sometimes that means scraping this tumor off with a scope. Sometimes that means bigger surgery, like a more radical surgery to remove the bladder, or radiation or chemotherapy, those sorts of things. Here's what a bladder tumor would actually look like when we do a cystoscopy in clinic. They typically look like almost a little piece of coral or a little papillary frond kind of coming off the wall of the bladder there. Treatment really, as I said, depends on the stage, depends how far deep into the wall of the bladder this has grown. And we usually start with an endoscopic resection. What that means is using a small scope or camera. This is done in the operating room with patients asleep to scrape off that little tumor. So here's a cartoon version, and then here's a real version of what it will look like. The cartoon version over on the left side of the screen here shows kind of what looks like a hot cheese knife slicing through there, and it's a cautery tool that we use to scrape off the inside wall of the bladder. And that's exactly what it would look like on the right side of the screen there. scraping that off. And so we're able to get those little bits of tumor and send those to the pathologist as well. They look at them under the microscope and then can tell, based on the normal sort of architecture of the bladder, how deep it's grown into the wall there. Usually treatment can sometimes include, in addition to the scraping procedure, can include either immunotherapy or chemotherapy on the inside of the bladder. We're at least we're lucky in the fact that the bladder is accessible via a catheter or a tool otherwise to put chemotherapy directly to the source. We can either do that at time of the surgery or what we call induction treatment, where we do a series of bladder treatments over usually the course of 6 weeks or so to provide chemotherapy right to the tissues that are at highest risk. Those more invasive tumors can sometimes require a bladder removal and then a diversion using a type of reconstructive procedure to bring the urine out in a different way. The main issue with bladder cancer does have a very high rate of recurrence. So even small tumors can sometimes be like a game of whack-a-mole where you take one out and then it'll pop up somewhere else. The reason for that is that the whole bladder has been exposed to the same chemicals, the same carcinogens throughout a patient's life. And so oftentimes it can happen in multiple places. So the surveillance protocols are usually pretty precise for these, and we see people very frequently in clinic. With chemotherapy, up to 50% of folks with higher grade cancers can have a recurrence, and so that's why really surveillance is key. And for better or worse, you get to know your urologist pretty well after you've had a bladder cancer diagnosis. The kidneys, so this is where, of course, the urine starts, can develop both benign and malignant or cancerous tumors. By imaging, we can't always really tell exactly what the tumor is, but more often than not, they are cancerous. Now, that's not to say that all of them require treatment or surgery up front, but just based on the imaging characteristics, the most common thing is what's called renal cell carcinoma, and that's a cancerous tumor of the kidney. But of course, sometimes benign tumors can masquerade and look pretty similar to it as well. Oftentimes happens in the 50s to 70s range, but can show up at any age. Again, sorry guys, men are slightly more likely than women, but the real risks are, again, smoking, high blood pressure, obesity, and some folks with renal failure or genetic issues can be at higher risk for kidney cancer as well. Oftentimes this doesn't show up with any symptoms, and so it's kind of a hard thing to screen for because most of the time we find it incidentally, just by happenstance. So very commonly someone will come into the emergency department and get a CT scan for abdominal pain or for another reason, and just by happenstance. The radiologists always look all through the body when they do, and many times our kidney cancer patients are found just by luck. And so while no one likes an ER visit, some people are happy that they did get that CT scan for one reason or another. There's a sort of classic triad of symptoms that happens only in less than 10% in this day and age, which is a flank mass or a side mass that you can feel. That's very rare these days. Blood in the urine, or called hematuria, and flank pain. So stuff that we don't see too much, and usually more in advanced cases in 2024. So treatment for kidney cancer really depends on the size of the tumor. Some of them we just monitor over time. So I'll show you a bit. Small tumors are very unlikely to cause any serious issues anytime soon. And so many times we follow these individuals with kidney ultrasounds, CT scans, or MRIs to see how fast the tumor grows over time. And this is very safe for many people. We, of course, do surgery, and we as the urologists are the ones that do this. Some tumors are large enough that we have to do what's called a radical nephrectomy, or removing the whole kidney. Some are small enough that we can remove just the tumor and leave the rest of the kidney behind. That's a partial nephrectomy. Some we can treat with ablation, which is putting a needle into the tumor and either cooking it or freezing it. And then some more advanced cases respond well to newer immunotherapies or chemotherapies. This is a kidney tumor here that you can see. The bottom portion of that bean there is occupied by a tumor. The top portion is more normal, and this was an instance where the kidney tumor was too big that the whole kidney had to come out, but it was all confined within the kidney. Here's an example. If you can see the little green line there, that's a small kidney tumor. And when they're like that, kind of dangling off the edge of the bean, you can do what's called a partial nephrectomy with this procedure here. So you can kind of see the tumor there, the dotted line around it, and we're able to remove just the tumor and then sew the kidney back up again and let it heal. So certainly pros and cons of both of these. The partial nephrectomy, while it's removing less tissue is actually a technically more difficult procedure. It's one also in this day and age we usually do minimally invasive with the surgical robot as well, and patients tend to do very well and recover very quickly from that. I mentioned earlier, this is a little bit of a busy table here, but if you look at the first 3 lines, those are small tumors, up to 3 centimeters in size, and the far right numbers there are the chance of having metastatic disease or cancer spread with those size of tumors. So when I said I'm comfortable watching, kidney cancers, this is why. When they're less than 3 centimeters, there's a less than 1% chance risk that they'll spread, and that's in huge case series, looking at lots and lots of people. Even when they get into the 3 to 4 centimeter, we're still talking low single-digit percentages. But they're, when you treat these, you're making an investment in the future, knowing that this is going to be something that hangs around for a while. And you want to avoid getting into, 5, 6, 7 centimeter range, because surgery becomes more difficult. Difficult surgery is not fun for anyone, either the patient or us. And certainly not as fun taking that risk that something bad could happen down the road. So in general, how can you not think about these at all? And so don't smoke. If you do smoke, quit smoking. Try to keep your blood pressure normal with your primary care providers, and maintain a healthy weight. And also knowing your family history is important. So if you have strong cancer history in one way or another, just because it's only been one sort of cancer doesn't necessarily mean that you're only at risk for that type as well. So talking with your family is always an important thing. Of course, urology talk around the dinner table isn't what most people probably talk about, but when you have the opportunity, it's good information to have. So I'll make a couple notes here now about those quality of life things that we see. These are some of the most common things that I see in clinic on a daily basis. Probably the number one thing that I get called about when we're on call is kidney stones. So kidney stones are no fun, but unfortunately lots of people get them. So 10% or more of individuals will have a kidney stone at some time in their life. The risk for getting a kidney stone, probably far and away dehydration or having concentrated urine is the number one. I mentioned the stone belt on here, and we're not really included in that, but especially in southern states, they're, with their warmer climate and lack of fluid intake can be a hotbed for stone disease. You can probably, depends who you ask, but anecdotally seems like we do get a few more stones in the summer months with people being less hydrated. The reason for that is purely just concentration and chemistry. So if you have all the stuff in your urine to form stones, it's more likely to crystallize when the urine is very dense than when the urine is very dilute. There's some dietary things that can predispose you to having kidney stones, but oftentimes that's more a factor on an individual level, not something that's necessarily the same person to person. Obesity, diabetes, all of these health conditions can put you at a slightly higher risk for kidney stones, chronic urinary tract infections, and then there's some pretty rare syndromes that can happen as well. Stones come in a lot of varieties, so a lot of different chemistry can come together to form stones. The most common ones are calcium oxalate, but we see lots, including calcium phosphate, uric acid, infectious stones, and some others. Usually symptoms are not subtle if you have a kidney stone. I don't know if anyone's here had them, but oftentimes we're meeting these patients in the emergency department because the pain was severe enough to bring them in. It's usually pain in their flank, kind of wrapping around the side, sometimes moving down to the abdomen, can oftentimes include nausea or throwing up, and oftentimes blood in the urine or pain with urination as well. I'm not allowed to say this because I haven't had any kids, but the women oftentimes say that it's close to childbirth or even worse than childbirth, but I don't let any guys ever say that. Stones can really hurt, but stones with a urinary tract infection, that can be something very serious. And so when I talked about things that might shorten your life, this is one of them. So I usually say if you think you're passing a stone, it's fine to soldier on at home, but if you get a fever on top of that, it's time to hightail it into the ER. So usually then we take things a little bit more seriously on getting the kidney drained out. The reason for that, why it can be so serious, is because the interface between the urine and the bloodstream is only a cell or two thick up in the kidney. And so if the kidney's under pressure and there's a bunch of bacteria in there, the bacteria can jump across the interface from the urine into the blood very easily, and that's what can get you really sick, land you in the ICU and type of thing, and usually very treatable with antibiotics and a couple maneuvers from us, but something that we like to know about earlier rather than later. Usually diagnosis is with imaging. Oftentimes that's a CT scan. Sometimes it's an X-ray or an ultrasound. And so here on the screen here, this is a CT scan from a patient. the big white circle there in the middle, that's a big kidney stone that's being blocked up. And you can see it down on the kind of lower right of the screen over there on the image on the right.
Dr. Paul,
Yeah.
if you use your cursor, your mouse, and point it, people online can see it, and then...
Okay, perfect. Well, you can look at this here. So I'll circle this for the folks watching at home. There's a big white kidney stone there and then one over here. Thankfully, as urologists, we don't have to be too good at reading images because stones show up bright white and everything else is a sea of black and gray.
We don't see what you're pointing at either.
I know. They'll be able to see it at home. I don't think I have a clicker unless this will.
Well, it should be your mouse as you move the mouse around.
Yeah, I'm moving it on here, but
And it's not
yeah, it's not showing up on the screen. Here, let me,
If you move the cursor over to the
how about that? There we go.
left. Ah, there it goes.
Oh, there you
Oh, all right. Okay, perfect. Well, there's that. And here's this one over here. So this is the same stone, just shown in two different views. Perfect. All right. So that's, again, big white mark. And this is the left kidney up here, and that's the right kidney. So this is how this individual would have been diagnosed with a kidney stone. Treatment for kidney stones really varies depending on the stone. So some of them can be observed if they're up in the kidney. They usually don't cause too much trouble. It's when they jump out of the kidney down the ureter tube that drains it that they tend to cause pain. Some folks pass their stones, and that's great, and we don't have to be involved, and they can sometimes take some medications to help that happen. We can sometimes place what's called a stent, which is a small tube that goes up alongside the stone. That's usually what we do in a more emergent setting when folks have an infected kidney stone. That's just a tube that goes up alongside the stone and allows the kidney to drain and antibiotics to work, and then we come back to fight it another day and remove the stone. Probably the most common thing we do is something called ureteroscopy, big long U word, but that means taking a camera or a scope up into the ureter tube where the stone is, and we usually use a small laser to break the stone up into a bunch of little pieces and then fish them out with a little basket. You can also do shockwave treatment from the outside. Pros and cons to both of those, but shockwave kind of blasts the stone into smithereens, and then folks pass them on their own. For some very large stones, we have to do what's called a percutaneous procedure, and that's one that goes through the skin straight into the back. More invasive because we actually have to make an incision, go straight into the kidney, but we're able to manage very large kidney stones that way. This is a picture coming up here. So this is a stone in the ureter tube. This is the stone here, this big tan thing. And this is the little blue thing up there is a wire going up to the kidney. And so that same stone I just showed you on the CT scan, this is what it looked like when I took a look up into that ureter tube. And so this big tan stone here would have used a small laser fiber to chunk it down into a few pieces and then use a very small basket to remove it. The laser we use is about the width of a hair, so it's a tiny little thing, about 1/5 of a millimeter. So we're talking very small instruments and very small tools to get these done, but thankfully we're able to sneak up there and not cause too much harm and get these out in a very minimally invasive fashion with no incisions or much other trouble usually. Stone prevention is, of course, better than ever having a stone, and treating it is not having one at all. It really depends on the stone type. And so the first thing we do for people who have had multiple stones is a 24-hour urine collection. Again, not the most fun thing to go through, but you get a jug, and usually you spend a Saturday or Sunday hanging around the house going into the jug all day. But that tells us in a full day cycle of what the chemistry of the urine looks like. And so different people, some have too much of the stuff that forms stones. Some people have not enough of the stuff that prevents stones. But that collection really tells us, what levers we can pull as far as diet or medications or otherwise that might help prevent stones in the future. Hydration is really the key for a lot of people. The goal is for at least 2 or 3 liters of urine output per day. If you've had stones before, that's a lot of urine, and that's even more fluid intake than that because some of the fluid you take in, of course, is going to get sweated out or get used up by your body. And so keeping it to 2 or 3 liters of total urine output per day is quite a lot. A low salt and low animal protein diet is oftentimes what we recommend for calcium stones. You don't have to be a vegan or a vegetarian at all. This is probably the same kind of recommendations you'd get from a cardiologist or a primary care provider, but that can also help limit the amount of calcium in the urine and therefore calcium stones as well. it is a little bit backwards, but we don't want your calcium to be super high. That makes sense, but we also don't want your calcium to be super low. We just want that to be normal within the normal range. So the best thing to do for anyone is to drink more water. The next thing I'll talk about is benign prostatic hyperplasia. We call it BPH for short, or even more straightforward than that is just enlarged prostate. So, the women can tune out unless they're with someone that has a prostate. But this happens very commonly. So this is 70% of guys in their 60s, over 80% of guys, up into their 70s have some degree of bother or symptoms from their prostate. Symptoms of this are usually things like slow stream, not emptying your bladder out, waking up at night more frequently to urinate, or frequency and urgency throughout the day. The prostate's a gland that sits right underneath the bladder here. And so if you look at this picture up here, that's the bladder, and then the prostate sits right underneath it. The prostate's sort of a donut-shaped organ, so it wraps all the way around the urethra tube that men urinate out of, and the urethra that you urinate out of is sort of like the donut hole. So as the donut gets bigger, this donut hole actually gets smaller, and that makes it more difficult for the bladder to empty out. It's got to work harder. Guys have to work harder, and that's what leads to a lot of the symptoms from prostate enlargement. We oftentimes have you fill out this annoying score when you come to clinic, but this really just quantifies those typical symptoms that I mentioned. So what does it feel like when you're emptying your bladder? How frequently or urgently are you going? What are things like? And then I think the bottom question here, it's a little bit hard to see, but how has this impacted your quality of life from an overall bother? Because there's certainly guys that have a lot of symptoms that don't bother them that much. There's some guys that have a medium amount of symptoms that are more bothersome, and that's really just a personal thing, but helps us match up what we can do and how it can help guys out. The diagnosis is based on lots of things. So, of course, a history, some scoring systems. Oftentimes we will do a couple tests in the office, especially if we're considering doing a procedure or a surgery. That cystoscopy, that camera look in the bladder like we do for bladder cancer, we also times will do for prostate enlargement as well. And that's really to see what the inside anatomy of the prostate gland looks like. Because sometimes it's not purely size, sometimes it's the shape of the prostate, the orientation. We'll do prostate sizing with imaging like ultrasound or CT scans, sometimes MRI. We'll do a flow test in the clinic where we hook guys up to this contraption that measures how fast the urine comes out and the pressure at which it's coming out. We also want to know how much is left over after guys go. A little bit is okay, a lot is a different story, and sometimes that helps guide the next steps in treatment or observation. There's a couple medications out there. The two sort of workhorses are one called tamsulosin or Flomax. The name is pretty self-describing there, and that it kind of helps open the pipes. There's one called finasteride or Proscar that kind of shrinks the gland down. A lot of guys in our practice are on one or two of these medications due to their symptoms. Then there's a lot of surgeries and procedures that we can do on the prostate. There's some minimally invasive ones. This is one we do here called the Urolift, which is you're actually not removing any tissue. You're just taking this channel and making it bigger here. So you're opening it up right there. It uses a couple actually little clips with a suture in between, and you tension them down, squeezing that channel open. That's a less invasive one, usually a bit less chance of bleeding. We can actually do it in the clinic for some guys, awake with just local anesthesia and numbing, but doesn't pack quite as big of a punch. The transurethral resection of a prostate, a lot of guys call it the Roto-Rooter procedure. That's kind of the gold standard historical one. So here in the middle, you can see a scope looking in. This is done asleep under anesthesia. And all of this enlarged prostate tissue, you use the same type of scope that you would have used for that bladder cancer and core out, making this little tiny channel a big wide opening. And so that's something that we definitely do pretty frequently as urologists. And then there's bigger surgery for guys that have really huge prostate glands. We'll do what's called an enucleation procedure. Best way I can describe this to patients is imagine taking an orange. If the prostate's the orange, we're going to remove all the fruit from the inside of it and leave just the peel behind. And so this is something we also do with the surgical robot. And so this would be a view, of course, cartoon view, looking down from above, actually through the bladder, and using cautery tools to open up this entire prostate here that was in the way and make it a nice big open channel. Urinary incontinence can affect, of course, both men and women, but see it more in our practice for women that come to clinic, and it can be up to 50% of women having some degree of incontinence in their life. Stress incontinence is usually a little bit more frequent, what that means is leakage with coughing, laughing, lifting, sneezing, kind of just leaking that you don't feel. Your bladder's not squeezing, it just kind of comes out. And that's contrasted with urge incontinence, which is usually an incontinence that you feel like your bladder's squeezing really hard, overactive bladder, can't make it to the bathroom on time. And then a lot of women have mixed urinary incontinence. And so that's where you kind of unfortunately get both of those happening simultaneously. And, the treatment then depends on which one of those types of leakage bothers someone most. And so that also is a very quality of life dependent decision on where we focus our efforts, but there's lots to do for both of these things. Risks of developing incontinence is, older age, any sort of neurologic disease, things like diabetes or dementia. Folks that have recurrent infections can be at a little bit higher risk. We actually talk a lot about the GI tract in the urology clinic because constipation or not having a regular bowel movement, at least on a daily basis, can make the bladder go a little bit haywire because the rectum sits right up against the bladder. So a big poop ball within the rectum can push on the bladder and cause all sorts of trouble. Folks who aren't getting around quite as well, of course, if you can't make it to the bathroom quickly, more likely to have an issue with leaking on the way to the bathroom. And then for women especially, if you've had childbirth and especially vaginal deliveries, can increase the likelihood of incontinence and particularly stress incontinence. The diagnosis of this is a lot of history. I take your word for it of what the leaking looks like and how much it's happening throughout the day, but oftentimes includes an exam, oftentimes a pelvic exam in the office. We look at the urine to make sure there's no urinary tract infection. We look at the post-void residual. What that means is the leftover amount. We want to make sure that the bladder is indeed emptying itself well. Sometimes we also look in the bladder again with a cystoscopy in clinic. And then there's some really fancy tests that we can do called urodynamics, which is bladder pressure testing. That's a little bit of a invasive deal with a catheter in the bladder and filling it and emptying it. But when cases don't look straightforward, before we do anything permanent or irreversible, we want to know exactly what we're dealing with, and that's probably the best way to figure that out. So a couple treatments for incontinence here. Really, it depends on the type of incontinence. So for stress incontinence, we always start with behavioral modifications, and that can mean, limiting your fluid intake at certain parts of day. A lot of times it's sort of pelvic floor training. People think that it's just sort of Kegel exercises, but we actually have, specific pelvic floor physical therapists we send a lot of our patients to. And this is not the same physical therapist who's probably working on your hip, your rotator cuff. This is someone that's a little bit of a niche branch of physical therapy, but can be very helpful in coordinating the pelvic floor to do its job more effectively. There are some things like bulking agents, which are actually injections that we put into the urethra. Like I talked about the donut of the prostate, if you imagine a donut again, but this time it's the urethra, this is putting a water gel essentially into the wall, trying to squish the wall so it closes more easily and holds the urine back better. We can also do things like slings, which are little pieces of either mesh, or we can use your own fascia actually, or strength tissue from a variety of places to kind of make a U that goes down underneath the urethra and helps hold it up and keep it closed. Urge incontinence treated differently, but still starts with oftentimes behavioral modifications and physical therapy. So training the bladder to work to the best of its ability and to work when it should and not work when it shouldn't. Urge incontinence does oftentimes start, however, treatment with medications. So there's a number of medications that kind of relax the bladder, calm it down, stop it from contracting so aggressively. Beyond that, things get a little bit more invasive. So we'll actually do Botox injections into the bladder. Same exact thing that folks get in their face or otherwise. All it is a muscle relaxant. And so if you administer it into the bladder, it's going to relax the bladder muscle and make it not squeeze so heartily. And then there are things, as a picture of what we would look at when we're doing the bladder Botox. Again, something that we do with a scope, looking in the bladder and giving a number of injections across the back wall of it. And the other things that we can do for urge incontinence are actually types of nerve stimulators. So another thing that seems a little out in left field when you first think about it, but a lot of the bladder misbehavior is due to poor signaling that's coming down from the brain and vice versa, going back and forth. And so you can stimulate one of the sacral nerves, which is one of the nerves very low on the spinal cord going to and from the bladder, It's almost like a pacemaker for the bladder. It provides a very low level of stimulation that helps regulate and restore that bladder-brain connection. And this is something that, of course, we usually don't jump to right away. We work our way up step by step, starting with the small things, the things that are low risk, and working our way up to the things that potentially have a bigger payoff but are more invasive. Lastly, I want to talk about urinary tract infections. So probably the most important thing here is the definitions of what all goes into what's a urinary tract infection. And so just having bacteria in the urine does not mean you have a urinary tract infection. So we call that bacteriuria, which means there's bacteria in the urine. But to actually be classified as having an infection, you got to have bacteria in the urine and you have to have symptoms from the bacteria in the urine. So the symptoms are a key thing. Just having bacteria in the urine isn't necessarily always a bad thing. There's some people that walk around with urine that's colonized with bacteria, and if you're not having symptoms from it, unless you are either pregnant or having a procedure by me in the near future, we usually recommend not treating that with antibiotics, mostly because the antibiotics will only breed more resistant bacteria or mess up your good bacteria in your GI tract and otherwise. They are uncommon though, so up to 50% of women or 12% of men will have a urinary tract infection at some point in their lifetime. A number of medical conditions can put you at risk for urinary tract infections. Anatomic abnormalities, things like stones, if the plumbing isn't set up quite normally, can put you at risk. If you have an indwelling catheter or any sort of catheterizations, sometimes sexual activity. For women who are older and postmenopausal, a low estrogen state can also put you at higher risk for urinary tract infections. And then a big one we see is incomplete bladder emptying. So if the bladder's not emptying out all the way, it's providing kind of a trough there where bacteria can set up shop, grow, and divide. And if you imagine walking through the woods and seeing kind of a pond next to you, it's probably got pond scum on top. And if you look across the way and see a creek that's moving quickly, no scum on that creek. And so that's why essentially the bacteria are constantly trying to creepy crawl inwards from the outside world. And the more that the urine can flush through and flush them out, the less likely it is to develop an infection. And the reason, the big difference between women and men here is that, the female urethra is very short, a couple centimeters long, and the male urethra is about this long. So not quite a foot, but it's a much longer trip for a bacteria to get into the bladder of a man than a woman. This is what it would look like here. As I said, kind of the creepy crawl backwards. This is, of course, a heavily zoomed in view. They're not really this big, but the bacteria can come from anywhere. But usually they're coming from the skin or bacteria that are typically residing in the gastrointestinal tract can make their way down and around up into the urinary tract. A number of different bacteria and other things can cause infections, though. So symptoms of a urinary tract infection are often things like burning, frequency, urgency, pain in the bladder or the abdomen. Certainly if it's a little more severe of an infection, having things like fevers or back pain if it's a kidney infection. Oftentimes, folks will complain of smelly urine or funny looking urine, but those things are very unreliable for diagnosing a urinary tract infection. The main reason for that is lots of things in diet and otherwise can make the urine look weird and smell weird, and it's not something I typically rely on, in and of itself as an infection. Of course, if it's happening in the setting of those other symptoms, that's a different story. Usually the diagnosis is made on symptoms, but also some lab tests. We usually get a couple things: a urinalysis, that's a dipstick test that we can do quickly in the office, a urine microscopy, and a urine culture. And so sometimes we do imaging, but oftentimes not. The results that we would get here, this would be the urinalysis. And so there's a couple infectious markers down on the bottom of the screen here. One is called nitrite, and the other is called leukocyte esterase. And those are the most positive markers for a urinary tract infection. The leukocyte esterase is more sensitive, meaning that it's going to pick up more urinary tract infections. And so if this is negative, very unlikely to have a urinary tract infection. The nitrite is positive, or is more specific though. And what that means is it's more reliable as far as if this is positive, it's very, very, very likely that you do have a urinary tract infection. The other things we'll look at is a urine microscopy. And so this is actually looking at the urine under a microscope that they do in the lab. And the things we typically see up here is elevated white blood cells. That's just an immune response, getting white blood cells to fight the infection there. And oftentimes they can see bacteria. And this one, it was rare, but sometimes it'll say many. seeing bacteria themselves swimming around in the urine. And then finally, the thing I care about the most is the urine culture. And so this is where they actually drop the urine onto a little plate and see what grows. And they have a number of criteria they look at in the lab to see what type of bacteria is growing. And then they essentially put a little drop of antibiotic all over the plate, a different antibiotic in each drop, and they see which antibiotics it's sensitive to and which ones it's resistant to. And this was a case where everything they tested it against was sensitive, but sometimes you'll have one that is resistant to a couple of antibiotics and sensitive to a few others. And sometimes we've started someone on one antibiotic and we have to switch at a later date based on this culture result. Treatment of urinary tract infections, the hallmark, of course, is antibiotics, because as I said before, if you're asymptomatic, not having any symptoms, and you have bacteria in the urine, we usually don't do any treatment at all, and we wait for symptoms to start. As I said, unless you're pregnant or I'm about to do a procedure on you, I usually do not recommend treatment in these scenarios. Antibiotics, the type and everything, and the duration depends on the severity of infection and type of bacteria. We usually do not recommend retesting urine after a treatment course of antibiotics. If it was an antibiotic that was tested in the lab based on the culture to be appropriate for that bacteria, we usually don't recommend retesting as long as symptoms have improved. Prevention of urinary tract infections, again, I'll come back to, you can kill two birds with one stone here, specifically with the stones and the urinary tract infections, and drink a lot of water. Additionally, emptying your bladder to a greater degree and getting more urine out per urination. The other things that have been tested out and actually studies that are supported by our urology guidelines are cranberry supplements or drinking 100% cranberry juice. I like the supplements because they don't have as much sugar, and you got to drink a lot of cranberry juice to really get the benefit from that. And also being on a probiotic or just eating yogurt a couple times a day. For women who have gone through menopause, vaginal estrogen can be very helpful. It's a very safe form of estrogen. It's not absorbed throughout the body, and it is helpful in restoring the normal pH or acid-base balance of the vagina and the urethra. And what that does is it helps more good bacteria enter the area and outcompete the bad bacteria. And lastly, a daily antibiotic is something that we talk about for some patients, but we like to avoid that for the reasons that I mentioned. It can breed antibiotic resistance, and it can also a little bit screw up the good bacteria that are present in the GI tract. So just, parting words of, well, when do you really need to see a urologist? We're nice people, but not everyone needs to see us. For men, if you've had an elevated PSA test, and that's that prostate screening test, that's something that should pretty much immediately prompt a referral to a urologist. Anyone who has blood in the urine, especially painless blood in the urine, that's something that we never really write off to any cause, and we have suspicion to look into further. This is a little bit of a thing for the younger generation, but anyone who's got a testicular mass or testicular pain or swelling should always see a urologist for that. Anyone who's had a CT scan or an MRI for other reasons, if it shows something funny in the urinary tract, that's something that we should probably see you for. And then on the other side of things, of course, if you've ever had a kidney stone, we're happy to see you, if not to treat it in the acute setting, to focus on prevention. And I say if you're urinating too much or not urinating enough, however that function has swung, we're happy to see you. Folks who are having recurrent infections or sexual dysfunction as well. So with that, I'll open the floor to questions. If anyone has anything that they're burning to know about urology or about any of the things I mentioned.
That burning was an interesting word choice. I'm coming around with the microphone here.
Got a couple.
Okay, this
questions.
is
Oh, Tim, go ahead.
All right.
me. Okay,
Go ahead, yeah.
you're going to be our doctor soon. We're on your, but he has a mass inside his kidney, and they've been watching it a few years in West Des Moines, and then we transferred up here. How big does that have to get to be? It isn't cancer. He had for a year we thought it was cancer. He had a biopsy then at Methodist. It wasn't cancer.
Right. So, benign tumors of the kidney can look just like cancerous tumors, but You bring up a good point. We don't always do biopsies for kidney tumors. Sometimes we go straight to treatment. Depends really person to person. Sometimes we will get a biopsy before we do treatment. If you've already had one and it's benign, in general, that's something we typically still follow with imaging, but don't necessarily, need to treat unless it gets large or starts causing symptoms.
Okay, thank you.
Tim, go ahead and ask your questions online.
Okay. I hear that oxybutynin for urinary incontinence has an increased risk of causing dementia. Is that true?
Yeah, so some of oxybutynin is in a class of medication called an anticholinergic. There's a couple other names for it, but it's really, historically one of the big workhorse medications for overactive bladder, urgency, urged urinary incontinence. And while it does work great, it does have some side effects, like most medications do. The main ones are it can cause dry mouth, can cause dry eye, can cause constipation, and then, like you brought up in the question, there have been studies that show that it can increase the risk of either acute confusion or delirium, or potentially even increase the risk of worsening dementia down the line. And so that class of medications, one I take pretty seriously. After age 60 a little bit, after age 70 a little bit more of prescribing. There's one medication in that class that actually doesn't cross the blood-brain barrier. That's probably a little bit safer for folks. But that's one good reason that sometimes, you want to avoid a certain class of medications and maybe, either stick with something that's less aggressive, like physical therapy, or sort of leapfrog over it to do things, like bladder Botox, et cetera, that, seem a little bit more invasive, but may not have the systemic or whole body side effects.
Okay, and your second one, Tim?
And what about the med trospium? Can it be taken long term?
Yeah, trospium is actually the one I just mentioned, that it doesn't cross the blood-brain barrier. And so it's typically, from a cognitive standpoint, slightly safer. Still can have the same, dry eye, dry mouth, constipating side effects. But in general, pretty safe to be taken for the long term, as long as people are tolerating it well and not having major side effects from it.
Yes, I had just recently learned that, retinol can raise your vitamin A, but also I've been studying over these vitamins that I've had to take. What about calcium causing blockages? Like I got to take extra calcium.
So from a kidney stone standpoint, I want your calcium to be relatively normal. So in the normal range of what the recommended dietary intake is, usually about 1,000 or 1,200 milligrams of calcium per day. Mm-hmm. Too high, it makes sense that can get into the urine and potentially put you at a higher risk for kidney stones. Too low, it may actually also raise your risk of kidney stones because it doesn't bind up some of the stuff in the stools to flush out. Now, I always say that, I'm operating in reality here, that many people have other things going on in their health, besides the thing I'm seeing them for. So if someone has severe osteoporosis or low bone density, that might take precedent over stone prevention for a particular person. And so, the last thing I want is someone to stop taking calcium and have a hip fracture or something else horrible happen in the, guise of trying to get their kidney stone prevented. So it's really on a personal level, where that fine line is and what the best thing is per person.
And another question is, what if you've got the sling and you've had to take the pills for incontinence and all these things are still happening? Now I'm going to be getting shipped to Grinnell to see a doctor. What else could be going on with all that?
Well, again, it's really, especially anytime someone's had a couple things done, either been on medications or specifically had surgical treatments of the bladder, kind of all bets are off on what happens. And so those are usually circumstances I'm a little bit more thorough and aggressive in the, diagnosis of looking into things. And so, where, all else equal, I'll be more likely to probably look in someone's bladder with a scope to make sure that there's no abnormality there, either anatomy or, a foreign body or something. And also probably be a little bit more thorough with the testing, with the bladder function testing and knowing exactly how that bladder is functioning. Garden variety, symptoms are different if someone's had a bunch of prior work done and prior surgeries, just because it can kind of change the risks associated with doing yet another thing.
My question is sort of two-part. One is, are kidney stones usually made of calcium?
Most of the time they are.
And that's why not to take too much calcium. One thing I had read was to take K2 with calcium because D3 helps it and to get it in, but K2 directs it into the bones rather than into the kidneys and things like that. So I've seen D3 and K2 sold together for that purpose, I think.
Would you agree?
Certainly not my wheelhouse as far as osteoporosis preventing, but I think it's perfectly reasonable. I don't think it probably changes your risk of stone prevention all that much. The people I worry about when I say too much calcium, I'm talking about people throwing down calcium chews every hour during the day, people that are really overdoing it, 2-3 times the amount of calcium that's recommended. That can probably put you at a little bit of risk, but we want people to be getting, the normal amounts and recommended amounts.
Is cystoscopy and endoscopy the same?
So an endoscopy is really just any sort of procedure where you're using a scope to look somewhere. And so I would say cystoscopy is a form of endoscopy. Most of the time when they're talking about endoscopy, it's either an upper endoscopy looking down into the stomach or a colonoscopy where you're looking from down below. A cystoscopy, we're looking through the urethra and into the bladder specifically.
Relative to that, then cystoscopy is a form of catheterization?
Sort of. It's essentially like a catheter. It's just got a camera on the end of it.
Is there an alternative for males?
Not really.
Oh. I know what that means.
Yeah. There's only one route into the bladder, and I think you're onto it.
I think that was a collective for everybody here. So, yeah.
I just have a quick question there. Since we don't do a whole lot with the prostate after age 70, is a PSA test still beneficial, or is it a waste of time?
Yeah, it really depends person to person. After those are the general screening guidelines. In reality, we follow a lot of guys with their PSA, up to age 80 and beyond. It really just becomes a discussion between each individual patient and their provider, both their primary care provider and oftentimes us, as far as what their preferences are and what overall health looks like. If certainly age is not the most important thing when you compare people's health overall. Some 80-year-olds are in great health, some 50-year-olds are in poor health, and vice versa. And so, age is important, yes, but it's certainly not the end-all be-all as far as making recommendations.
I've had a couple of friends lately that have had kidney stones, but they were branching, not round. Mm-hmm. And so could you say something about that?
Well, it depends how big they are. They come in all different shapes and sizes, but some, especially larger ones inside the kidney, we'll call them staghorn stones, but they actually tend to start filling up the kidney. And those are usually the circumstances where we do a more invasive kidney stone operation, one where we, instead of going, with a scope from down below, we'll actually poke a little hole in the back and go in through a tube straight into the kidney and break the stone up. We're able to use some essentially higher powered tools and get more stone out faster that way. That would take a really, really long time to do any other route.
I've also heard a couple of people who their major symptom was just, I guess, mental confusion, and they didn't have temperature, didn't have pain, and it took a while to find out that it was a urinary infection. So what should you look for something like that?
Well, it's a really hard thing, especially as some patients are dealing with dementia or mental status changes at baseline, is figuring out, well, what exactly is going on, because some patients can't tell us exactly how they're feeling, and maybe they are experiencing something but not expressing it. It's really part of an overall workup. I say I never want to get too focused on the bladder because a bunch of other things could be going on, but there definitely are occasions where everything else in someone's health seems normal and there is a bacteria growing in the urine, and those are situations where we probably would treat for a urinary tract infection. If there's really no other explanation when you look head to toe for what's causing a change from someone's baseline, then oftentimes, we'll treat for that.
Last question. Are there any of these conditions that are more common in Iowa than other places, or more common in rural Iowa than in urban Iowa?
That's a good question. I don't think to a great deal. We're pretty middle of the road, I think, as far as, seeing kidney stones and other things. Now, anecdotally, sometimes I think some people think that chemical exposures of any kind can put you at slightly higher risk for cancers of any variety, and certainly a lot of our farmers here are exposed to chemicals on a pretty regular basis. But there's no, hard and fast evidence to that. I think it's more of just something some people notice and may or may not be actually true on a big scale.
What is the relationship of high blood glucose diabetes to urinary tract infections, and how? I know you have to control your blood sugars, but there are times when it's just way out of range, and then there's problems.
Right. So the association, especially for diabetes and urinary tract infections, is it's sort of twofold. One, if your sugars get high enough, you're going to spill some sugar into the urine, and bacteria love sugar, and so it's going to be way easier for them to grow and divide, if they are in a very sugary drink rather than a glass of water. And then twofold, in general, poorly controlled diabetes, where your sugar levels are higher, does suppress your immune system slightly. It just makes it harder to fight off bacteria. And so, the combination of those two, your immune system not knocking them down quite as much and the bacteria having an easier way to grow and divide, is really just a setup for getting an infection.
Could you speak to the possibility of the pH balance in the system having an effect on bladder problems or urinary infections? I have GERD and I have a very acidic system, and so I was wondering if, like diet, things that are acidic, if that would affect that.
So the main sort of pH thing that we see is in relation to kidney stones. And it really depends on the type of stone that you're getting. So there are some kidney stones, most notably uric acid kidney stones, that form in a very acidic urine. And there's some kidney stones, primarily calcium phosphate stones, that form in very basic or alkaline urine. And really, having a acidic or basic system, most people probably still won't get a stone based on that. But if you do get stones and we find that there is that kind of metabolic pH disturbance, that's one of the things we oftentimes use to our advantage in preventing stones. So we'll do medications or supplements to push the pH balance in one direction or another.
But does it affect the bladder?
I don't think it really affects the bladder.
Can you tell us anything about PKD, polycystic kidney disease?
Yeah, there's a couple. So polycystic kidney disease, there's a couple of them that are common. There's a autosomal dominant polycystic kidney disease. That's the one that most adults have. There's a rare autosomal recessive polycystic kidney disease. It's a more serious thing and really little babies. But kidneys can form cysts on them, and cysts are just little fluid-filled, almost warts on the kidney. And most everyone in this room, majority speaking, probably has a cyst on his or her kidneys, and so. They're benign, they're fluid-filled things. They're not normal in the sense that not everyone has them, but the majority of people, especially once you're kind of after the age of 50, will develop, some amount of cysts. And they're nothing to worry about. They just sort of happen. There are a couple genetic syndromes that I mentioned that you can get a ton of cysts on your kidneys. And so instead of like a wart or two, it looks like almost like a water balloon, just all sorts of cysts on there. And you can also form cysts in your liver and some other places as well. But, it can put you at a slightly higher risk for kidney dysfunction, a medical kidney dysfunction. We, of course, deal a little bit with that, but it's more of under the nephrology umbrella, more of the medical kidney doctor umbrella. When we're taking into account, kidney cancers, we'd probably follow those patients a little bit closer with imaging. Kidney dysfunction is one of many risks that can put people at a slightly higher risk for having a cancer of the kidneys. A lot of time those folks are followed with regular ultrasounds and other imaging, either by their nephrologist or us, just to make sure the kidneys, are looking okay.
If somebody's in the older adult age group, but they've not really had issues, still you recommend the cranberry type supplement and things like that? Is that?
No, I think only if you're having recurrent infections. If you're not having recurrent urinary tract infections, don't worry about it. It's really for those patients that are having usually, 2, 3, 4 infections a year, we'll sort of write off 1 or 2 a year. But when it becomes more than that, usually some sort of intervention is helpful.
Okay, and I think Tim has something online to share.
Yeah, we had one tip for emptying bladder. She says, leaning forward has helped me a lot.
There you go. All right.
Are there any medications that if you already have kidney stones that will help dissolve them?
So there's only one type of kidney stone. It's the uric acid stone I mentioned earlier that can actually dissolve. All the other stones, once they are formed, they are there. And the only way to get rid of them is doing a procedure to blast them or break them up. Now, there are medications that you can take to stop the formation of stones and stop them from getting bigger. But only the uric acid stones can dissolve, and the way to dissolve them is to change the pH balance, like we talked about, getting a more alkaline or basic urine, making the urine less acidic. It doesn't happen quickly, but they can dissolve over, probably weeks to months.
Okay, I'm on the Ubuten, and the last time I went to the doctor, they said they were doing research on it, and they told me to quit taking it right now. Did you say there was something that might be a similar?
So yeah, there's a number of other medications for overactive bladder or urgency. One is called trospium, probably a little bit safer from a cognitive standpoint, from a mental standpoint. There is a second class of medication. It's called, there's 2 on the market. One's called mirabegron or Mebetric. One's called Vibegron or Gemtesa. That one you see ads for a lot. Whenever you see ads for medication on the TV, it tells you it's going to be expensive because it's new and it's not generic yet. So that's the main issue we run into, honestly, with that class of medication is getting it covered. And so
I know they gave me a prescription, and I went to the pharmacy. It was $650 a month.
Exactly.
And I said, I don't think I'm going to choose that.
Right.
What, can you spell the other one that you?
Yeah, Gemtesa is Gemtesa, I believe.
PESA. Okay. Okay. Thank you. Well, they were saying that Ubuten is being tested because of what do I want to say? Memory issues. Yeah. And it's like, okay.
Yeah. Right.
Other questions? Wow, we've had a lot of questions today. Did we get them all? All right, Tim, no other ones online?
No other online questions.
Okay, wonderful. Thank you so much,
Appreciate
Dr.
it.
Paul.
Thank you, guys.
Wow, you covered a lot of areas, so that was great. You're a wonderful presenter, so thank you. And lots of great questions today. So just want to remind everybody about our upcoming programs. Next week, Thursday, in here, April 4th, 2 p.m., we have a program on why should I use my chart? And then the following week, Tuesday, April 9th at 2 p.m., we're in here, a program on dementia friends. And then we have our day trip to Pella for the Tulip Festival, May 2nd. We have 2 spots left if anybody's interested. And I have a flyer up there in the back. Want to remind everybody about the Senior Expo coming up Thursday, May 9th, and that will be at the Gateway Hotel. And you don't have to sign up for the Senior Expo, but all of the programs, you can just go to our website and sign up for those. So please fill out your evaluations. There's a basket on the back table. You can put those in. Thank you for coming, everyone, and have a great day.